Good afternoon, everyone, and thank you for joining us. I'm Margaret Drew, and I am chair of the ABA's HIV/AIDS Impact Project. I'm also associate professor of law at the University of Massachusetts School of Law. We are thrilled to present this webinar, HIV/AIDS at 40, Perspectives on the Struggle. This webinar is sponsored by the ABA section of Civil Rights and Social Justice, the HIV/AIDS Impact Project, and the Center for Human Rights. During today's program, we encourage you to ask questions of our panelists through the Q&A, not through the chat function. If you do not see the controls, please ensure your screen is not idle. We will address questions at the end of the program. We will be sharing a recording of this program to everyone who is registered so that you can share it within your networks. This program commemorates the 40th year anniversary of the Center for Disease Control reporting on a rare pneumonia observed in 5 men from the LA area. This condition would later be called acquired immune deficiency, or AIDS. AIDS has killed over 700,000 people with disparate impact on treatment for the disease on people of color. The ABA established the AIDS Coordinating Committee during the early days of AIDS. This was organized in 1987 to identify, analyze, and address legal and policy issues surrounding the HIV/AIDS pandemic. And in so doing, the committee helped inform public policy efforts to protect both individual rights and public health. Since then, the project has produced comprehensive ABA policy on the broad range of legal issues implicated by HIV, published reports and monograms examining such issues, and convened panels to discuss and debate them. Since 2002, the project has held a biannual HIV Law and Practice Conference, welcoming HIV legal and policy professionals nationwide to examine cutting-edge issues, share practice strategies, and strengthen bonds as a community of advocates. The next conference will be held this coming May in New Orleans, and we encourage you to follow the project's website for forthcoming details. On behalf of the project, I would like to thank Michael Pates, who is director of the ABA Center for Human Rights, who has expertly guided the committee and its members through many years of challenges presented by HIV and AIDS. Thank you also to Paula Shapiro and Ali Kilsgard, who provide amazing support to the HIV project. And with that, I would like to begin our discussion. We will begin today with Armen Merjian, who is senior staff attorney with the legal department at Housing Works in New York City. If you would like to begin. Yes, and it may be that Mike will be joining us for this discussion also.
Sure. Well, good afternoon, everyone. And I've been asked to speak today about the long struggles and the long history of HIV and AIDS in this country, obviously with parallels to the pandemic, but important distinctions of the pandemic that are going on right now. And I think my colleague Brad Sears will be talking about some of that as well. I want to start by just saying, especially, I'm sure we have a mix of folks, old and young, and so some of this will be rudimentary for folks who've been around, but I just want to say how startling it was in 1981 when a new civil rights struggle fell on us overnight, really. It wasn't just that there was a difficulty, a pandemic, and a new disease, but there was a disease that was visited upon folks who are already laboring under stigmas, under disenfranchisement. Gay folks, IV drug users, and communities of color rapidly, disproportionately live with this illness. And so because of that combination of the scariness, the lack of understanding of means of transmission, the deadliness of the illness, and the communities on which it was visited, we had overnight a new civil rights struggle. And I think it would be difficult for folks who weren't alive at that time to understand the kinds of discrimination, wholesale discrimination, that our folks faced from 40 years ago in every aspect of life, in education, in insurance, in healthcare, in employment, in public accommodations, from governmental units, just all over the country. And over a decade after HIV was discovered, and decades later, we still saw polls with alarming and disgusting responses from the general public who wanted to quarantine our folks. A huge percentage, a Harvard study showed 1 in 3 favored tattooing people who are living with HIV and AIDS. A huge percentage wanted folks to be tattooed or to have to carry ID cards demonstrating that they were living with the illness. A large percentage wanted our folks sent off to islands, to quarantined islands and away from everyone else. All of this sounds insane, and yet we're talking about well after the paths of transmission were known and well after we were dealing with the illness. This is the kind of wholesale discrimination and really disgusting mistreatment and injustice that our folks were living with. Another important hallmark is not just the total legal disenfranchisement and marginalization of our folks, but the fact that our Supreme Court refused, after 1981, over 25 times refused to take cert on any of these issues. So we got our first Supreme Court decision 17 years after HIV/AIDS was discovered in 1981. The Abbott versus Bragdon case was a 1998 Supreme Court case. And to put that in perspective, we already have coronavirus cases coming down from all of the courts, including the Supreme, stepping in with regard to real estate folks who are just desperate to get paid. And that's extremely important to jump right in there. But meanwhile, we had 17 years of silence from the Supreme Court. And we also had, folks may recall, a president in Ronald Reagan who refused to even utter the words HIV or AIDS during his administration. So we had a conflagration of rights. We had an absolute health emergency. Our brothers and sisters were dying in droves. And we had a Supreme Court abdicating its duty for 17 years, again, denying cert over 25 times. So our rights and our claims for justice were really being handled on the local and state level. If there are nerds like I out there who are interested, I wrote a law review article some time ago, the court at the epicenter of a new civil rights struggle. And that's in the St. John's Law Review. If you're a nerd and you're interested, it gathers all of the facts on this. But that's what we were dealing with. And what we found when we went to the state courts was a mixture of some decent rulings, and federal courts ultimately, and some horrible rulings. Some of them blaze trails that are being used now during the coronavirus epidemic, much to the benefit of folks who are living with it. We were sort of a training ground for so many of these rights, but some of them were awful. And I'd like to share some of the good and bad stories with folks so they have an understanding of what we were dealing with in this civil rights struggle. In New York, which was and remains the epicenter, we have more cases than everyone else. And for a time, we had more than everyone combined. And for a very long time, I think still after the spread of the illness, we were still at, I think, 25% of all cases nationally. We had courts very involved in this, but with a very mixed bag. Our Court of Appeals, which is our Supreme Court, oddly named, had a mixture of great decisions and just awful decisions. Just to take a few, the Doe versus Coughlin case was a 1987 case in which a prisoner was denied conjugal visits from his wife on the assumption that HIV would be spread in the community, even though she wasn't from the community surrounding the prison, and the prison had absolutely no right to step in. The prison was using mandatory measures when voluntary measures were the universally accepted correct approach to this illness. You see, there was no medication early on, and the understanding was that if you mandate measures, name reporting and testing, that the communities at issue will go underground. They won't test and they won't know their status. And the only way to arrest the spread was for people to have knowledge of their status. And so all of the great folks from Matilda Krim to Ronald Bayer to others said we have to use non-mandatory measures. Well, that's not what some in New York did. And in fact, not only did they deny conjugal visits, but even though the route of transmission was well known by 1987 when the case came down, the prisoner in question was forced to attend family visits, even by children, by parents, sitting in the isolation room of the hospital with a large table between himself and his wife or family members that would visit in 1987. So he was in an isolation room with a table, and they were only allowed to visit in there. And this was upheld by the Court of Appeals in 1987, well after it was known that HIV could not be transmitted. One of the ugly chapters, right? Because we often wrestle with two things. We wrestle with the illness, but we wrestle with not only society's misconceptions and prejudices, but with the courts as well. Another doozy came down from the Court of Appeals, New York's High Court, in a case, the Coughlin case. In the Coughlin case, the High Court of New York ruled that it was perfectly okay to use HIV tests to disqualify people living with HIV from insurance coverage, period. You'd think that insurance coverage might be a little bit important, as we see now with coronavirus, and certainly with our folks at the time in the late 1980s. It's a 1989 case, and it was based on the notion that covering folks who are living with HIV would bankrupt the insurance industry, and therefore it was perfectly okay to wholesale exclude our folks based on an HIV test. The fact was that it was known in 1989 that HIV was far less costly than numerous other health maladies, from cancer to heart transplants to renal disease. But those, of course, were not diseases that were visited almost exclusively or so disproportionately on communities of color and gay folks at the time. And I'll just say that that is always something in the background in these cases. And so the court, without any foundation, any factual foundation for its sweeping conclusions, concluded that it was perfectly okay to cut our folks off from insurance because it was going to bankrupt folks. And that was utter BS. If they had turned around and said, we won't cover cancer or heart transplants or renal failure or all these other things, would there not have been a hue and cry from the greater, larger community? But our community raised a hue and cry to no influence. So we had some really, really terrible decisions. We had some good ones, and I think I've been asked on the panel just because I'm getting old. And one of them was a case I worked on that's very relevant to what's happening today. It was the Society of Surgeons versus Axelrod, in which a group of ultra-conservative surgeons and Lyndon LaRouche, a name that older folks might know, attempted to force New York to declare HIV a communicable and socially transmissible disease, not because they are or are not in common parlance, but because it would trigger mandatory measures like name reporting and quarantining and so forth of our folks, which made absolutely no sense for the HIV community. And as I said, was against all public health knowledge that mandatory measures would in fact lead to greater spread rather than lesser spread. And thankfully, the court in a 7-0 decision agreed with us that the commissioner was within his rights not to declare it as such, and therefore not to trigger quarantining of folks living with a mortal illness and name reporting, which would only drive our communities underground. So that was a great decision by the court, and one that we still applaud to this day, particularly nowadays when we're looking at similar issues. We also had in the federal courts, even though the Supreme Court wouldn't take it up, a whole series of struggles that have redounded to the benefit, I think, of all disabled folks and folks who are living with coronavirus as well. One that comes to mind is the case of Henrietta D. versus Giuliani. And I will not make loaded comments, except that Giuliani was our mayor for 2 terms, and he gave rise to a whole lot of HIV litigation. And I'm pleased to say, ultimately, it made good law for our folks. In the Second Circuit, for example, there was no independent cause of action under the ADA being just such a huge tool for our folks, for reasonable accommodations. And I see Allison, my partner here, may have joined us, so I'll be short and wrap up with Henrietta D. Allison, if you want to jump in. But in Henrietta D., the city said that there's only discrimination based on disparate impact or disparate treatment. This old notion that traditionally in civil rights, you must treat differently in order for there to be discrimination. And of course, the ADA was hailed as a 21st century civil rights statute precisely because for the disabled community, sometimes to treat equally or the same is to discriminate, right? So think of a new opera house in town with stairs, beautiful marble stairs leading up. And the mayor stands atop the stairs and looks down upon people in wheelchairs and mobility impaired and says, we treat everybody equal and everyone is equally welcome to this new opera house. So we haven't discriminated because we treat everyone the same, even though, of course, the reasonable accommodation of putting in a ramp or a lifting mechanism or an elevator is, of course, necessary for our folks to have equal access. And the Henrietta D case, among other things, brought by the largest class of HIV class, I think, in US history, and certainly the largest AIDS and welfare class, found that the city must offer reasonable accommodations to people living with welfare, for example, home and hospital visits, right, owing to the nature of the illness, intensive case management, one-stop shopping, so folks didn't have to wait in disease-ridden waiting rooms for food stamps in one place and housing assistance in others. And so we established in that case that to fail to accommodate reasonably is to discriminate, even if you are alleging that you're treating the same, that merely treating the same is not enough for people who are disabled, including people living with HIV. So along with the bad, HIV has brought about a whole lot of good. And Allison, if you want to step in, let's see if we have Allison on this. If not, I'm happy to do it.
I think Allison's having difficulty with the audio.
Okay, great. Well, I will not take too much time. I think my time is just about up, but you can read about these struggles more, both in the early HIV cases, in some beautiful law review articles, not mine, of course, that have been written about this that will explain these struggles. But it really is mind-boggling how overnight we had to struggle to establish the rights of our community in every aspect of life. And again, some of those struggles continue now with coronavirus, but there are important differences, and I think Brad and others might touch on those. I thank you for your time, and I welcome any questions perhaps that will be posed to all of us. I'm happy to jump in as well.
Armen, before you wrap up, I would be interested in hearing some of the good news, other good news that has come out of the struggle.
Sure. So here's another example that comes to mind. In the case of Hannah versus Turner, we were able to establish the first case in US history that established the rights of homeless people living with AIDS to same-day placement in emergency housing. So important. In New York, the welfare offices would close and they would tell folks, come back tomorrow. They could even do that in a blizzard. And we had plaintiffs that had T-cell counts in the single digits, whose immune system was horribly compromised, who would wait all day at the welfare office for a housing placement, being homeless. And there's a right to shelter in New York, which was, of course, an important wedge to be able to use there. But they were sent out into the snowbanks of New York and told, come back tomorrow and we'll place you. And often they failed to, but the point was that folks who have a T-cell count in the single digits who are homeless and living with AIDS being sent out into New York was a recipe for not only suffering, but quite possibly death. I will add that Mayor Giuliani also declared concomitantly upon failing to house folks that homelessness itself was illegal and that you could be arrested for the act of being illegal on the street. So it was an unbelievable conundrum for our folks. And we were able to establish same-day placement in medically appropriate emergency housing. Our folks are given their own rooms in what's called SROs, single room occupancy hotels. A hotel is an SRO. Because at the time, all New York had to offer were congregate shelters, shared shelters. And early on in the epidemic, studies showed that folks living with HIV were 500 times more likely to contract tuberculosis. And once contracted, of course, it was often a death sentence because it's hard to fight off tuberculosis when your immune system is shot. And the great news there is that we were able to use that precedent to get folks who were homeless during the coronavirus into hotels as well, rather than into congregate shelters. And so the lessons we learned from HIV were used to save lives for homeless people in New York during the pandemic. And it worked out well because, of course, hotels were hurting. There's a travel ban. No one was coming to use the hotels in New York. So you had all of these wonderful hotels and hotel rooms going fallow. And you had homeless people who were staying away from the congregate shelters because they didn't want to die from this horribly transmissible coronavirus. And Margaret, we were able to use that precedent and that knowledge from HIV and AIDS to get folks their own hotel rooms during the pandemic and save countless lives, because there was a grossly disproportionate outbreak of coronavirus, as you might imagine, in the homeless population as well. So one of the real bright spots and transitions from HIV to coronavirus for us.
Thank you, Armen. And Allison, I see you were able to connect.
Yes, I'm sorry for the delay.
And it's quite all right. And I wonder if you have information you'd like to follow up on Armen's presentation, particularly what was going on in the early days.
Absolutely. I want to tell just three very quick stories. One, I think, is a story that's never been heard before publicly, and two that are stories that have been told, but I think are lesser known, and they have such a bearing, not just on the impact of the early days of HIV, but also the power of law. And so if you'll bear with me, I'll make them as short as possible. First of all, sometimes, as I was asked once in an interview, what was the greatest impact I ever had on the law? And, I've done a lot of things in my career. And I said, actually, it wasn't trying the first ADA case. It wasn't all these other things. It was in a phone call. There's a case called Bragdon versus Abbott, which roughly a young woman with HIV goes to a dentist, is essentially refused service. A lawsuit ensues by the gay and lesbian advocates and defenders. And ultimately what is at stake in that case is something that had maybe the greatest impact on people with HIV for the 20 years following. And so let me explain. So young, brilliant Justice Department lawyers at the deposition of Sidney Abbott. And you have to remember, this is under the old definition in the ADA, where you had to show a substantial limitation of a major life activity to be covered under the law. And during the deposition, she had really testified that there was nothing that she felt substantially limited in. And so this young lawyer called me and said, isn't this a problem? And yes, it is a problem. So we had a long discussion and decided that she had never been asked the question about whether or not she wanted to have children. And at that time, it was really prohibitive for you to have and bear your own children if you had HIV without passing the virus on. And so I said, have that conversation with her. If it's true, you can't tell her that's something, you can't lead her, but if that is true for her, let's try that. And it turned out that it had impacted her ability to have children. And so fast forward, that case ended up in the United States Supreme Court. Is still the only case decided by the Supreme Court involving a person with HIV. And the question before them was whether or not a person like Sidney Abbott, who had HIV but didn't have any symptoms, could be covered under the ADA, the then premier federal, then really new premier federal civil rights law covering people with disabilities. And the person who did the appeal for justice on the justice side and GLAD side of the case was a young man named Sam Bagenstos. And by the time the case got to the Supreme Court, he was then clerking for Justice Ginsburg. So of course was recused from the case. But I do remember standing at the fax machine, and this was before everything was done by email, because we knew that the decision was coming out that day, hearing the phone ring and somebody saying, oh, Allison's going to have a good day. And then the fax machine started churning out what ended up being a 5-4 decision in favor of coverage. And so when we think back about that now, I mean, the ADA Amendments Act has sort of cleared all that up, didn't really happen until 2010. And so that's a huge amount of time where the potential was, if the Supreme Court had gone the other way, this enormous achievement of having a civil rights law to cover people with HIV, would have sort of gone away. And I think we would have been back to the original days which you referred to, in which legal tools were really largely missing. I mean, we had the Constitution, there were a small number of state laws. 504 covered a little bit of this, but not very much. If you've ever seen the movie Philadelphia, there's actually I play it for my law students every year, a clip of Tom Hanks researching 504 in the law library. That doesn't happen too often. And so that's one story. And I think so that is a story of the power of law to enhance people's lives and to ensure their civil rights. I want to go back a little bit further into the days of the passage of the ADA and credit a woman named Pat Wright, who was really the general marshaling all the resources during the passage of the Americans with Disabilities Act, the original version of it. And she was really responsible largely for the politics. And a Southern senator named Jesse Helms, and I'll leave it to your discretion to have views of that or look him up. But he really wanted people with AIDS, as most people were known then, people with AIDS to be excluded from the ADA. And he had marshaled some folks in support of that. And Pat Wright, who was really with the Disability Rights Education and Defense Fund, who were running things, had to decide about that and stood on the steps of the Congress and said, we're going together or we're not going. We are not going to allow you to split us up, and we will not agree to that. We will have the bill pulled before we will allow this separation. And so again, I mean, that's the power of having the guts to say no to a lot of powerful people. There was a huge risk involved in that. But it's unimaginable to us today that the ADA would not be covering. Going back again to the early days, I was in Chicago then, and I've asked that there are 3 or 4 books I really recommend that people read if they have a continuing interest in this. But in the early days in Chicago, it was awful, right? I mean, it was just incredibly awful. The human toll was awful. The suffering was awful. The fear was awful. And you were just, we were all just drowning in it. And a friend of mine named Bon Foster had what we used to refer to as one of the really bad experiences with death. I mean, they varied a lot, but he was one of the people who sadly was plagued with just about every type of infection you could have gotten. I mean, and it was a very long and very difficult process for him to leave this earth. And before he passed, he decided that he wanted the bulk of his estate to be used to open a Midwest office for the Lambda Legal Defense and Education Fund. And that is, in fact, what happened. So the Chicago office was really funded by his estate. And, our colleague and friend Scott Shottis, who has done such brilliant work as the HIV project manager there for so many years. I just want to say publicly, how proud and grateful I think Bon Foster would be of all of his work and all of the work that had come out of that office from his predecessors. And I don't know, if that work would have happened in the absence of that or not, or at the same level or not. But these are sort of the hidden stories, right? Of the power of people coming together. I think the overarching message from the early days is this: when you're in a room full of people and you realize that if something doesn't happen, and I mean right now, in a year, those people are all going to be dead. And we're all going to be living with the consequences of that. Gives people a sense of urgency that allows them to put aside everything else, all the petty politics, all the petty personal stuff, and join together to rise up as one body of people to accomplish something that has to be done, and it has to be done immediately. So those would, kind of be my views.
Thank you, Allison. We look forward to your joining in when we have the question and answer period also. I didn't have time to acknowledge you, but among many of her other works that she does, Allison is an adjunct professor of law at Georgetown School of Law. So next I would like to introduce Dr. Michelle Collins-Ogle. And Dr. Collins is, Dr. Ogle rather, is attending physician, pediatric infectious disease and adolescent medicine at Children's Hospital at Montefiore. So thank you for joining us today, and we look forward to your information on what has happened over these 40 years.
Great, thank you so much. Can you hear me?
Yes.
Great, thank you for inviting me. And thanks for all of this great information and history from the legal perspective on how far we've come when it comes to providing just the basic rights for people living with HIV. If I might, I'd like to share. Can I share the screen? Can you give me share? I have a couple of slides to share with you that basically sort of walks us through from a scientific perspective on how we've sort of gotten where we are with HIV. Looks like I can't share. I need sharing. I need sharing.
Allie should be able to give you share screen powers. Let me see if I can. Let's see. No. So if Allie's still on, the doctor needs ability to share.
Yeah, yeah, go ahead.
Okay.
Everyone,
No
yes. Apologies. Yes, Dr. Collins-Ogle, you should have the ability to share. Do you see the green button at the bottom of your screen?
Yeah, but it's not showing it's showing, hold on. There we go. I think I got it. Yay.
Thank you.
Right. Medicine is amazing. Technology is something different.
So yeah, just make sure that you present.
Great. So basically what I wanted to do is just share a little bit about how we've gotten to where we are, basically, where we're actually now talking about people living with HIV and actually having a cure, not just a functional cure, but a real cure. So 40 years later, I'd like to say that HIV remains a tough target. It always has been, and now 40 years later remains that way. And I like to remind people that this is a retrovirus. People are now trying to equate HIV to coronavirus, to flu viruses. This is a retrovirus. It's not like other viruses. This retrovirus is really good at tricking your cells into making more copies of itself. And that's how it's remained such a formidable viral foe for 40 years, when we've managed to get other viruses under control and actually managed to cure other viral diseases like hepatitis C, for example. So this is just to walk you through a little bit about how we've sort of gotten where we are. If you look at the top of the screen on the left, you'll see really until the 1980s, there really wasn't much going on in the way of antiviral medications or antiviral studies, for that fact, in trying to cure viral diseases. If we go through to the early 1980s, we see some medications to cure viruses, or to treat viruses, I should say, acyclovir being one of them, very early on in the days, to treat herpes viruses. If you move to 1986, remember our first case of AIDS was actually documented back in 1981, but it wasn't until 1987 that we actually had antiretroviral medication to treat the disease. During this time period, I was very, very early in my career. during my residency and my fellowship, actually, in infectious diseases in Detroit, at Children's Hospital in Detroit. And we were seeing these babies born with this virus that we learned was, AIDS or HTLV3 or GRID, as we all know the different names and different iterations that the virus has gone through over the years. But initially, there wasn't really much we could do, right? The best we could do was try to treat the underlying infections that these babies often had. But to actually try to get the virus itself under control, there was nothing. Now, this is a fun fact. Zidovudine, or Retrovir, which we call it now, is, everybody sort of wonders, or back then I would wonder, where do we get AZT from? Why is it called AZT? But it's Zidovudine. And this medication was originally azithromycin, and this medication was actually developed back in the 1960s. So this is a fun fact, that AZT was not like the first medication that was, that first antiretroviral that was actually developed for the treatment of HIV. This medication was originally developed in the 1960s as an anti-chemotherapeutic agent, and it failed miserably. So they put it back on the shelf, and then with a lot of pressure from advocates and many people that are on this webinar, the government was pressured, and the scientific community was pressured to do something. People were dying, and again, for me, it was horrible because I was taking care of babies that were dying miserable, horrible deaths. So Zidovudine came off the shelf, was the first antiretroviral used in the treatment of HIV, and it was rebranded. It was no longer azithromycin, it was now Retrovir or Zidovudine. So that's just a fun fact. As you move into the 90s, what I'd like to point out is, for the beginning part of the 90s, there wasn't a whole lot going on. There was monotherapy, which was all we had to offer. And again, treating the underlying illnesses, underlying infections. But monotherapy was sort of the gold standard at that point. So there were medications being developed to be used in the treatment of HIV, but alone as monotherapy. But it wasn't until like the mid 90s where we really got this, I would say, a really big explosion in understanding the mechanism of infection of HIV and understanding why monotherapy wasn't working. Because remember, we still had people dying. Maybe we prolonged life. Maybe they got a little bit better quality of life during this time, but we still had many people dying, including babies, including children, living with this virus. So we were learning quickly that monotherapy wasn't going to get us very far. And again, remember, this virus is a tough target. This virus develops, it mutates, it has other things that we've learned over the decades, cofactors to help bind the virus to the cell, many things we didn't know about the virus then that we learned during these 90s and the early 2000s. And in this period of time, you'll notice that we learned, again, monotherapy wasn't going to get us very far, and we started using dual therapy. So 2 antiretroviral medications from different classes. The Zidovudine was an NRTI, and then we started the protease inhibitors developed in the late 90s, mid to late 90s, were used in combination with Zidovudine and other NRTIs. And again, we still had a lot of viral failure. We still had a lot of people dying and a lot of people progressing to AIDS. I call this period like the late 90s to early 2000s. It's like the most hopeful time during that time in my career, where we actually felt like we were doing something for people besides making them god-awful ill, taking these cocktails. The time that we started using triple drug combinations and other medications for the treatment of HIV, we had people, including babies, including kids, having to take 24 pills 3 times a day, or taking other, for a lot of the babies, we had oral suspensions made that were just disgusting. And we're asking parents, we're asking caregivers to give these medications to these babies and to other people who were living with AIDS at the time that also required caregivers to give these god-awful medications 3 times a day, sometimes more, depending on how ill the individual was. So it wasn't until in the early 2000s and on into the mid 2000s that we really understood the power of triple therapy and using medications that were highly effective, that had higher barriers to resistance than some of the other medications, again, that we used earlier on in the epidemic. So this time in the late 90s, the early 2000s, when we started using triple drug combinations, we really understood the virus and the mechanisms by which it escaped. The antiretrovirals that we were using, how it developed resistance, the mechanisms for developing resistance, and it gave rise to these other antiretrovirals that were, kind of broadening the classification of antiretrovirals. So we've progressed in the early, 2000s to Fusion or enfuvirtide, which it's an entry inhibitor. Again, another classification of antiretroviral medication that we used in combination with other antiretrovirals to help treat people living with HIV. And then we've gotten to this place now where we have these very highly effective antiretrovirals called integrase inhibitors that have very high barriers to resistance. And now we're back to where we were back in the mid 90s. It's a little bit scary for some of us who've been around a while, but we're actually looking at dual therapy with these highly effective antiretrovirals that have done a great job in not just giving people who are living with HIV a better quality of life, but actually lessening the metabolic side effects that we saw so often with these medications, where we're doing a great job trying to keep the virus under control, but then causing problems in other organ systems within the body. So, if we look at from where we started in the 1980s to where we are on this slide to the 2000s, we've done a great job in the scientific community. We've done a great job in encouraging people to take their medications and for them to understand the power of being undetectable. So that brings us to where we are today. And again, this is the power of science, and this is the power of advocacy, and many people, again, that are joining us today to understand that we have to do better in terms of providing a better quality of life for people living with HIV. So now we're actually in 2021, where we have the first long-acting injectable that was approved for use, licensed in the United States in January of 2021, goes under the name of Cabenuva. And I'm sure people have seen the advertisements for this. We have been very excited about long-acting injectable. It gives people another option for taking antiretrovirals, particularly people now who are living very long, productive lives. Now we have an injectable that you can come to see your physician. You don't necessarily have to see the physician, but you can come to the clinic. You get one injection a month. This injection involves, it's actually 2 injections. The cabotegravir and the rilpivirine are not combined together, but they're given in 2 injections. But this has been liberating for people who don't want to think about taking antiretrovirals daily, or they have problems tolerating oral medications, or for a whole host of reasons that require us to think of better ways to improve adherence and also to continue to make sure people have sustained durable viral suppression. And these medications over the years that I outlined to you has given us, the ability to have some really significant clinical trials that have given us landmark legislation on U equals U. And so just wanted to highlight a little bit. There are several trials, but I would say these were landmark trials that really changed the game, really changed how we are able to advocate for people living with HIV. And also many of you in the law community, many of you who have been doing this work for decades, now you have another tool and another way to try to reduce stigma against people living with HIV. So for those who go back as far as I do into the ACTG 076, this is the AIDS Clinical Trial Group 076, this changed the game in terms of understanding the power of AZT, remember our failed drug from back in the 60s, the power of using zidovudine to reduce the transmission of HIV from mother to baby. So we learned that AZT being given during pregnancy and back during this trial actually had a substantial reduction in vertical transmission of HIV in a cohort of infected women, as well as their infants. So this sort of gave us data, hard data, to say something that we were saying all along to people. If you take your medication, you're less likely to transmit because you're not as sick. Your viral load is decreased. Your CD4 count is higher. So we knew these things intuitively, but these landmark trials, particularly ACTG 076, gave us actual data to show that we can prevent maternal to infant transmission of HIV with the use of antiretrovirals in the case of 076 AZT. Then we move forward to another huge landmark clinical trial, HPTN 052, which the results of this study was like heard across the world in May of 2011. And this gave us the concept, hard data that says treatment is prevention. And in the HPTN 052, it was a randomized clinical trial that demonstrated antiretroviral therapy reduces the sexual transmission of HIV and HIV serodiscordant couples by more than 96%. Again, this was a landmark trial, sort of helped us move forward again in understanding that people who are living with HIV that are virally suppressed and on antiretrovirals they do not have the cooties. They are not going to transmit the virus to you, and we can sort of start, working with stigma and trying to settle this, whole discussion that we're still having 40 years later about the transmission of HIV and treating people with HIV like, again, they have the cooties, which they don't. I know people who have cooties. People with living with HIV do not have cooties. So if we look at other trials, HPTN 052 gave the way for subsequent trials to also drive home the point. Treatment as prevention, remaining durably virally suppressed, reduces the likelihood, and we say virtually zero chance of transmitting the virus to another person through sexual transmission. Studies, opposites attract. And again, if you want to geek out, these are great studies to look at the data on. These studies show thousands and thousands of condomless sex acts and the near zero transmission of HIV in these studies. And this has given rise to where we are now, where we're trying to get people to understand that people living with HIV who are durably virally suppressed, who are undetectable, are untransmittable. They do not transmit the virus during during condomless sex. So when a person living with HIV is undetectable, they will not transmit HIV. This is something now that advocates, and particularly those in the law community, are working really hard to make sure that people understand that message and, again, try to reduce stigma of people living with HIV.
Thank you so much, Doctor. That was a wonderful history and gives us comfort for the present. And next, I would like to introduce Brad Sears. Brad is the Associate Dean of Public Interest Law at UCLA School of Law. He's Interim Executive Director and David Sanders Distinguished Scholar of Law and Policy at the Williams Institute, UCLA School of Law. And Brad is someone who is living with HIV. We look forward to your perspective, Brad.
Thank you, Margaret. And I think that's that last qualification is what I'm mainly going to speak from today. As someone who's a little older than 40 and has been living with HIV for almost 3 decades, the presentations have been great so far, and I just kind of want to bring them together in how kind of the changes in medicine and science over the last 4 decades and the legal changes kind of shape society, but also shapes identity and shapes a life. And I'm going to do that, obviously, coming from a position of being very privileged. I'm an attorney, I'm white, I'm male. I spent a lot of days asleep at my desk because of HIV, but I've always had a desk to sleep at, is how I would put it. But I want to walk through kind of my own personal experience and then how these developments, both in the medicine and science and the law, have kind of just shaped who I am, and then some of the challenges that remain today. And I'll say that, kind of my legal career and my experience being HIV positive greatly overlap. I stopped getting tested in law school because that was in the early 1990s, and I was worried about the results and thought I wouldn't finish law school if I found out during that time that I was HIV positive. I graduated in 1995, and that summer a movie came out called Kids, which was a movie about young people in New York having sex and doing things with each other and transmitting the virus. And I remember that summer watching that movie in a movie theater and feeling kind of the lymph nodes on the back of my neck, which felt like the size of grapes at that point. They were hurting, and realizing that I really needed to get tested because I was starting to show some of the symptoms of initial infection. I didn't quite get tested then. I moved from New York to Los Angeles, and a week after I got to LA, I had not my HIV test, but an HIV test, which at that time, it took 2 weeks to get the results. Unfortunately, that was a long 2 weeks to wait. During that time, I was called and told it would take a little longer, which was not good news. And eventually went in to a women's health clinic here in Los Angeles and got my test result. And even though I knew a lot about HIV, I'd been involved with ACT UP, it was shocking. I was kind of just frozen in that room. And I have to say, I was so lucky that the person who told me I was HIV positive was a woman who's HIV positive, who let me sit in a chair in her office for about an hour, who gave me a hug, and who immediately sent me to the other side of an LA to attend a peer support group meeting from an organization called Being Alive Los Angeles. So within 2 hours of being, knowing that I was infected, kind of sitting with a group of other people who were infected and being able to kind of share that experience. I was at that time, it was thought you might have like a decade with your own body being able to fight off the infection before you developed AIDS. I was not in that category. I was in a category called rapid progressors. And so my first T-cell tests were kind of in the low 300s. That was in the fall of 1995. I had an AIDS diagnosis by the end of 1995, beginning of 1996, defined at that time as my T cells falling below 200. And at that time, when I talked to my doctor, it was actually Scott Hitt, who was the Hitt Commission, was I think the first kind of presidential HIV commission, and Scott was a doctor here. Said, the rough outline was I had 6 to 18 months to live when I got that initial diagnosis. Fortunately, as the doctor just laid out, 1996 was also the year that kind of this combination therapy, the cocktail therapy as we called it at the time, became widely available, and I was put on those medications. Pretty much when they moved out of the clinical trials and were able to be available to everyone, that was like March 96, and then literally that month I went on them, and that was the first set of drugs that I went on. So just in talking, and again, kind of linking about how this shapes a life, I was 25 at that time. I had just finished law school, but then feeling that you only had a half a year to maybe 18 months to live, obviously was devastating. The news about the medications had been so dismal for so long throughout the early 1990s, as only kind of maybe delaying the disease for 6 months to a year, and then it would pick right back up. It was hard to have a lot of hope even in the medications at that time, and they were rough. The first set of medications I went on quickly gave me kidney stones, and so I had to go off of that. The second set of medications, I think I took them twice a day, not 3 times. I think I was over 20 pills a day. I was taking a lot of things to ward off opportunistic infections initially as well. And I was taking one kind of a gel pill that I think was a Norvir or Fortivase, and I had to be refrigerated. And it stunk to high heaven. And if you didn't refrigerate it, it really stunk. And so I was trying to go to work and not tell people kind of what was going on. And I had to manage these large, stinky pills. And so things like what, Allison talked about, like things like the ADA, like the ability to say, hey, I need time off, or I need a refrigerator to put these pills during the day, were very important to even be able to continue to work. I was fortunately working for a judge who was in his late 70s at that time. And when I told him, who just reacted wonderfully, and I think we would both go in and sleep in our chairs a lot. It took me about 2 years to really be able to fully function again, I would say. The pills would kind of give me a freezing kind of feeling on my face and my hands and feet. I felt like I had a kind of a headache and low-grade fever for about 2 years, but they worked. Sometimes I would take them and throw them up right away and have to take them again. But I stuck with them despite the side effects, and they worked. And then the side effects went away. My body adjusted after a couple of years. At that point, we didn't know how long they. I mean, I had been on them as long as about, except for the people in the clinical trials. And so, my doctor at some point, I said, well, how long do you think this is going to last? And every time I went in and got my blood work done, it was so stressful. It was like, is this the time it's going to end? Is this the time it's going to end? Eventually he said, well, we have no reason to think this would last 5 years. And that stuck in my head. But that also became kind of a time limit. Like, I don't know what's going to happen with my life. It's hard to plan a course of a life if I don't know what's going to happen in 5 years. So psychologically, the advances, these were the kind of key milestones for me. The idea that since I had already had to go off one set of medications to give me kidney stones, to only take the ones that maybe have a frozen face and throw up, psychologically knowing there were many alternatives out there, if those stopped working or if I couldn't handle them, that was a huge relief, because we were always worried about like building up resistance and then what options would be left. And so in that arrow going down in all those drugs, it was such a relief to know, hey, I have another option if these stop working. A little bit later in time, moving from multiple pills a day that were refrigerated, tasted awful, to one pill a day, was such a difference in kind of how I thought about myself as this person kind of constantly medicating and constantly feeling the presence of the medications and the side effects is something that I could tolerate, take once a day, and then not really think about, not only for 24 hours, just, a nice aspirin-like pill to pop in my mouth once a day was a huge psychological difference in how I felt about my life and the future of my life and my health. And I would say it was probably a decade after being on protease inhibitors that I finally felt I might live a normal life course. That kind of being thoroughly kind of digested by me took a long time. There was so much fear around the drugs eventually not working. And then I would say the final kind of big change in just kind of how I thought about myself in relationship to other people was the last information that Dr. Collins-Ogle presented, which is on kind of U equals U, that if my viral load is undetectable, which by and large it has been now since 1996, I cannot transmit the virus. I am not a danger to others. I am not a vector of disease. And so much of that discrimination and in discrimination, in employment, in social settings, but also in relationships, being able to have relationships, being worried about whether people could become infected. It's a lot, it's a lot to carry around, and people took their time in this country to let us all know that research had been done and that it was established that we actually couldn't transmit the virus if the viral load was undetectable. As you can tell, as my voice is cracking up, just a huge difference in kind of the conceptualization of self and with community and with other people. And so those medicines have made a real difference in how people live their lives, the quality of their lives, and how they kind of think and feel about their future. And Allison was mentioned the Bragdon case, and I think one of the kind of major life activities that Justice Ginsburg latched onto that has impacted by everyone who has HIV, at that time, and I think to some extent today, is that ability to plan for a life, to make decisions and project yourself ahead into the future. So in addition to the kind of the changes in medicine and science over the last 4 decades, the changes in law have also been dramatic and shaped society and kind of shaped, I think, how people view themselves. And so if you go back to 1996 and we think about kind of discrimination, kind of the state of family law, and criminalization in 1996, Bragdon had not been decided. It was not at all clear whether the protections would be available widely against discrimination from HIV, and the kind of norm and value setting that a major Supreme Court decision does had not been decided in 1996. Most states didn't have laws protecting you from discrimination on sexual orientation or gender identity. Unfortunately, a lot of states still don't today, but that definitely was part of the context for a lot of folks with HIV at the time. If you think about family law, there was in 1996, there was no marriage, no civil unions, no domestic partnerships. There was kind of a landmark case in 1989 in New York called Braschi, which was about somebody's partner being able to keep a rent-controlled apartment in New York after the partner died with HIV. And then part of the legal landscape at that time was families coming in, not being supportive of their LGBT children, and kicking partners out. And after someone died, really kind of disrupting people's stability, and all of the great caregiving that was going on in families, in community, was not supported or recognized by law. And so it's just a huge difference today that over the course of really the last 2 decades that recognition now is in place, and that people's relationships and families are protected, which aren't just about a bunch of legal rights, but about kind of the economic security that can bring. And then when you think about criminalization in 1996, Lawrence versus Texas had not been decided, still constitutional to prohibit sodomy in my home state of Missouri. I was, a felon for that reason. I think kind of somewhat a creation of the AIDS epidemic was the adoption of disease-specific felonies and criminal laws through HIV criminalization that the majority of states still have. We've done a lot of research here on them at the Williams Institute, kind of documenting the thousands of people across the country who are impacted by those laws, mainly people of color, disproportionately women who have HIV, and people who are sex workers. But the criminal law still sending a message of kind of stigma, and that people with HIV are a vector of disease, and not taking any of the information that the doctor just went over into account, but still sending kind of this very old and outdated message about the epidemic. And so I think all of those things help as well, right? They all are kind of lead to more, are the result of, and both lead to more social acceptance, kind of impact communities, and impact how individuals kind of feel about themselves. And I guess I'll just end with this, in some kind of comparisons about where we are kind of with COVID today, is that pandemics, they don't start with the first infection, and unfortunately they don't end with effective medications or a cure. They kind of run along the disparities that exist in society. And for HIV, that ran towards people of color, LGBTQ people, people who are marginalized, like sex workers and intravenous drug users. And while there's some reasons in the science and medicine for that, I don't think they're the predominant reasons at all. And I think that's shown by COVID, which we could have predicted 2 years ago would run to exactly the same places. And we've seen studies after studies show that people of color are disproportionately impacted, And we've done some research, and now the CDC has released some new data that LGBTQ people are also disproportionately impacted because of COVID. And why is that? That is because of the kind of entrenched economic disparities that people of color and LGBTQ people face. I think a lot of the issues I was just talking about and how law and science impact identity and mental health are true today, and also impact those communities as well. I think it is true in 2021 that I now know more gay and bisexual men who have died of suicide or substance abuse than HIV, and that's somewhat an artifact of my age, because I was was 18 in 1988 and not in 1980. Or those numbers might be different, but those disparities, the kind of societal exclusion, the challenges, I think that LGBTQ people still face, still have health consequences with COVID, with substance abuse, with suicides and other types of illnesses. And so I think the challenge is to get out ahead of the next pandemic, which isn't just about putting in place kind of vaccines or cures for the current one, but really continuing to address these entrenched inequities, and to address, it's every time kind of universal healthcare is called for, the cost is always seen as a part of the opposition. And I remember the last Democratic debates, it was like people were, the pushback was on the cost of providing universal health care. Well, somewhere on that balance sheet needs to be the cost of the COVID pandemic. If people enter this pandemic having healthcare, not worried about costs, not knowing where to go for their doctor's appointments and tests, we would have had a very different course of the pandemic. And so I think kind of moving forward, it's another important thing to take into account. So thank you.
Thank you, Brad. That was amazing. And when you talk about the suicidality, as you were describing the early medications and all the difficulties around that and how that impacted how you felt about yourself, I was wondering, in addition to all the stigma and with the medical treatments, rates of depression and suicidality must have been overwhelming, even more overwhelming then. And so next, presenting for us is Evelyn Thomas Weskey, who is in the she is the Master of Social Work Program Director and Assistant Professor in the Department of Social Work with George Mason University. Thank you, Evelyn.
Thank you very much. And I am going to share some slides, and I work well with structure. So I'm going to work from there. And I think this really connects to, where'd y'all go? To what you're really talking about, Brad, in terms of suicide and mental health and depression. But what I want to start with is trying to close my screen, but you know what? We'll just go with what I have on it. Is the idea of impact and response. And we think about, people were dying and people were grieving. I think back into my own personal experiences, and that this really created informal communities, informal social supports, those that honored the lived experience and used peer support. And I think for many of us, that was shown in our doing quilt, connecting, coming together across the nation and creating something that helped in some ways with grief, maybe brought people together who were isolated. And I bring this up as a start because it was really difficult and sad, but also touched in our resilience and our connection and our wanting to come together to do something. And part of that were mental health providers, creating resources, creating change, and also needing to understand the impact of HIV and AIDS. And I think that like attorneys who are there on the front lines, fighting for civil rights and fighting against discrimination, that mental health providers were on the front lines as well. And we were creating early mental health services And I found these books on my shelf, so I had to take photos of them. But these books on the left is Responding to AIDS, Psychosocial Initiatives. That was published in 1987 by a professional association, NASW. And the one on the right, Mental Health Care for People Living with and Affected by HIV/AIDS, was clandestinely published by SAMHSA in 1990. But part of that is that we were also building mental health resources in community. I remember volunteering at Whitman Walker Clinic in the early 90s, doing this thing called peer services, developing peer mental health services, because there was nothing in existence. And for any of you who know Whitman Walker Clinic at the time or even now, I think it's called Whitman Walker Health, sorry, but other services, these are all much more formalized, but these started with us in the community responding to really to pain and wanting to do something. We also created resources for providers. And the other thing I want to talk about is the great impact of mistrust and stigma and discrimination that emerged at the time and continued. And out of that came some publications. I don't know if you remember these, but the one on the right is We Can Do Something About AIDS. It was published by those in the industry, movies, TV, popular folks, back in 1988. And on the left is Report of the Surgeon General. Yay, the Surgeon General, 1987, making that connection. So coming into people's homes. Remember that report? I wish I had a copy of it. It came to our door from the Surgeon General. And that was really the beginning of a very slow government response. So I just want to put that in context, that all that we have now, or what we wish we had more of now, really began with community and people responding, and perhaps responding because of pain and anger and anguish. The other part of that I touched on is HIV and continued mistrust. And I think it's important as we look at mental health. That Iran Corporation survey taken 3 decades into the HIV pandemic, 2005, found that nearly 27% agreed that AIDS was produced in a government laboratory, and 53% agreed there's a cure for AIDS, but it's being withheld from the poor. Seems like a long time ago, but we would think in 2005 we would get it. People would have a greater understanding. But let's look forward. In 2016, a survey was done of Black Americans. And in 2016, 31% said that HIV was man-made, and that the US government is withholding a cure for HIV. These are profound numbers. And another thing that I want to bring in here is current issues. The Pew Foundation research in March 2020 found that 29% of Americans believe that what was then called SARS-CoV-2 was developed intentionally in a lab. And this was given great institutional legitimacy by then President Trump. So just putting the context in which we were living and currently live, and how that impacts and affects our mental health. So this is a couple things from the ACREA research. Evidence points to an urgent need for better access to mental health care. Up to 47% of people living with HIV experience anxiety and are 2 to 3 times more likely to experience depression. This data is from other research. These topics on the headlines are from ACREA. According to NIH, persons living with depression and another chronic illness can have more severe symptoms of both illnesses. Half of those surveyed were taking medications for anxiety and depression. What does this translate to? Like with the diagnosis of depression, we also can feel like depressive symptoms, kind of like diminished concentration, feelings of guilt, lack of energy. And these have been strongly linked with a worsening of HIV health outcomes and an increase in other health outcomes and mortality. And Brad touched on that when we think about suicide as an outcome in terms of depression. So the research has us thinking, how can we maximize effectiveness? We need to better understand depression. The evidence shows that it can suppress the immune system. It contributes to and exacerbates the cognitive decline of our normal aging. It correlates with difficulty in adherence to antiretroviral medications and other medications. And also, I want to note that when we think about this connection, what more can we do? What do we need to know? The National HIV/AIDS Strategy talks about community-led programs. How can we ensure that the voices of those living with mental health issues, diagnoses, chronic disease, substance use, the syndemics of the pandemic, how can we ensure that these people are engaged and part of the solution? I also want to remind us to look at mental health on a continuum. And this next slide is from data that was culled from members and allies of the Professional Association of Social Workers in HIV and AIDS. And it really looks at, this is what mental health and HIV service providers identified as critical issues around mental health. And again, looking at a continuum, we think of mental health, we think of depression, anxiety, the data that I briefly cited. But we're really looking at it from a biopsychosocial cultural lens, a broad continuum of not just mental health challenges, but the structural issues, the environment in which we live, work, and play, right? That stigma can create unhealth conditions. Stigma that we might feel living with a chronic condition can increase our unwellness. And then there's also the impact of self-stigma, ageism that we feel and we sense when we go for help, when we go ask a provider for help. Social isolation might not be identified as a mental health issue, but the impact that it has, it leads to or limits our access to information, our access to intimacy, to community, to family supports, all those things that we know that supports mental health wellness. Discrimination, touched on it, the impact of ageism, racism, heterosexism. Speakers have talked about that. And then chronic conditions related to HIV, that it creates earlier onset for other health problems that may be associated with aging, cardiac concerns, cancer. And then going back to stigma and discrimination, I think it's really important that we acknowledge the symptoms of historical and historical trauma and institutional trauma. And that this can, our history and the impact, and I think of racism, heterosexism, sexism, that this can impact how we perceive ourselves now and how we seek help. And as we are living longer, people are living longer with HIV and other chronic illnesses, that depending on their lens and their history, their ability to believe that they can reach out for help, or the ability to believe that what they have can be cured, or that there's something that medications they can access. We need to really look at some of the historical lens of how we've addressed HIV. I have one more slide two more slides because I want us to have time for some conversation, but I would feel remiss if I didn't make the connection of COVID-19 and HIV. Increased complications for persons living with HIV, treatment interruptions, and then increased rates of opportunistic infections. So really a connection. Looking at psychological impact, the isolation, increased anxiety for individuals with chronic health conditions. These are all based on literature, what we found in this brief year or 2 years. Can lead to maladaptive coping mechanisms. Again, Brad briefly mentioned substance use and overuse and self-medication. And isolation, social issues. And that we may have become many, and we know this if we work in AIDS services organization, people becoming separated from the very services that have helped them stay connected, stay well, and live long and live well with a chronic illness. I think we need to hold our government accountable. You know me, I can't get away without making a policy statement. You know, it's the idea of integrating programs to address the syndemics that people we know and love and work with have been living with HIV for decades, are newly diagnosed, are not aware that they're diagnosed, do not have access to medications, not just HIV medications, but mental health medications for other chronic illnesses. We need to really look at the factors as identified. So I would just like to end with that as a call to us to take this where we are in 40 years, this knowledge, this passion, this experience, and continue the good fight and ensure that the lived experience is part of that, and the voices of those here today, those watching, those that we work with, are part of this strategy that really makes change. Thanks. Margaret, are you on mute?
I am, thank you. So you didn't hear me say each of your presentations were wonderful and so informative. And first, I'd like to suggest, Allison, if you can access the chat, perhaps you want to put in the names of the 3 books you mentioned that you'd recommend for people who are interested in learning more.
Yeah, I sent those in advance to Allie, so she's got them.
Okay, great. And we do, first of all, I want to ask if any of you have questions for each other. We don't have a lot of time for discussion, but we do have some. And there is a question that I want to get to in the Q&A. But if you have questions of each other, why don't you ask them? Go to the Q&A. Okay.
Let's start with that.
All right. So one listener asks, there are a couple of counties in my state that do not have local organizations administering HAPWA assistance. People needing HAPWA in those counties have to move to a nearby county to receive assistance. Could this be a fair housing violation? It seems like potentially steering based on disability. Anyone have any thoughts on that?
I'll just take a step from the HAPWA standpoint. Those of us who are recipients of Ryan White funding note that there's legislative restrictions on those funds. And for example, if my clinic is located in a certain county and I'm funded for services within that catchment area, I can't necessarily provide services for someone, even though they may come to my clinic for care. But if they live outside of that catchment area, if they live outside of that area where I'm legally allowed to provide those support services, then you can't do it. So, we have had people in those situations that I would like to provide some services to, but they don't live in my catchment area, or aren't. I'm unable, because of where they live, I'm unable to provide certain services for them. So that may be an issue that has to do with, where the clinic is or where the catchment area is for the person with the Ryan White funding.
So it sounds less likely to be a fair housing issue as it is a statutory one. Is that a consensus? Okay, so one question, I know earlier in the chat there was a question about where to find the history of cases that Armen discussed. I don't know if you answered that in the chat or not.
In part of the chat, sure. With regard to how New York handled the crisis from the early days up through the Supreme Court finally taking cert, again, the law review article is entitled "The Court at the Epicenter of a New Civil Rights Struggle," and all of those cases are set forth there. With regard to so many of the others that we talked about, including the right to same-day placement in emergency housing, the National Treatise on AIDS has a section on housing. I'll sheepishly admit I wrote it, but I included all of those cases in there as well. And really, so many of the seminal cases in all areas, in employment, in immigration, in housing, are set forth in this wonderful national treatise that's been put out for decades now. And any practitioners out there that are looking for assistance and precedents in this area should start with the National Treatise on AIDS. There's just a whole lot of good stuff.
Thank you, Armen.
Could I just steal 35 seconds? I don't want, I'm, people who know me know that I am, I think it's so important that we pass along the history to the next generations coming up, the next generations of civil rights lawyers or social workers, whoever you may be. I don't want in all of the theory and the nicety about the law for it to be lost, what it is like to wake up on an average Tuesday morning and find out that everyone you know is dying of something you never heard of and you cannot stop. And that only changed. The government didn't save our lives. Medicine didn't save our lives. We saved our own lives. People got in rooms of 500 and 1,000 people because we didn't have email. We didn't have social media. We only had each other. And the power that was going to come out of those rooms with an understanding that we didn't have a choice. Losing was not an option. Silence really did equal death. It wasn't just a slogan, it was a reality. And it was from that power, as Alex Billings says so brilliantly, you have to reach across and you have to pull people by the hand and you have to rise up together. We built our own clinics. They were going to treat our people. We educated our own doctors. We changed the federal government. We changed the way the FDA does business. We changed the way the National Institutes of Health do business. We changed the way the Justice Department does its business. We did that. We did that because we were willing to put everything else aside in the service of getting people to live. And so as you go through your life and you get involved in protests, I really urge you to keep that in mind, the power of the individual as a collective. So I'll leave it there. Thank you.
And
I think it's very powerful for where we are now. I think, I know Bill's question earlier, the first in the chat about the ADA and what's happening with the Supreme Court. I think helping the physical visual of being on the streets, of really collectivism, is something that I would love for us to help others connect with. I see it with my students, and it's doing advocacy beyond social media. That's just one way to reach out. That there's that visual was really powerful, Allison. Thank you for reminding me. I'm sorry, Brad, I interrupted you.
Yeah, I thought it was really powerful too, and so spot on. And there have been studies of people of my age and older who were involved in ACT UP, talking about the mental health positive benefits of that involvement, and that it was a time, an awful time, but a time of great purpose, and where people really felt connected to community. And I saw the other question in the chat, and I guess I'll answer it a little bit tangentially like this. Everything what Allison said is so true. Like a community, sort of a group of marginalized communities rallied together to really protect ourselves and to protect each other. And part of that was caring about each other enough to take all sorts of precautions. And if you think it's hard to put on a mask or socially distance, asking a bunch of young people to change how often and who and what type of sex they have is a huge behavioral change. And I really contrast the two, both in the way that people rose to that challenge to protect each other and based on a sense of kind of community welfare, and the way that seems so challenging now for a big part of the population. In doing that. And I also have to say, which I remind myself too, is that there were a lot of people blaming people who got HIV for getting HIV. Then, and I'm sure even today, but it was not the community response, it was not the public health response. If it was not, were you foolish? Did you not have unsafe sex? It was, you're sick and we're going to take care of you. And I think that's an important message for today. Whatever you think about people not taking the vaccine or whatever, is that once someone is sick, what they need is support and care. So I think that's the other side of that coin, is that I wish people were more community focused today, and we need to remember that the kind of blaming and shaming that went on then, also is not a good public health response today.
Thank you all, and Allison, thank you for reminding us that community is the powerful tool. And for those who are advocating on any issue today, we know there are many, in addition to the stigma of HIV. That's an important message, that we've lost that sense of community in many ways, and you do need to come together without blame. So thank you all. This was a most informative webinar, and I thank you all for joining us. And thank you to our audience.
Thank you. Thank you for hosting.
Bye.
Everyone, act up and fight back and make things better.
Rise up.